All right. All right. Good morning, everybody. Thanks for joining for this week's AMSSM Sports Ultrasound case series. This is, I just looked at this last night. This is our 53rd presentation over the past couple of years. So we are moving along and building quite an excellent library of cases, thanks to people like Doug, who's presenting today, and all the fellows in the past that have done an amazing job. We've been really proud of the library that's been put together. And I think today is fairly fitting to have Doug Hoffman joining us. He obviously is the mastermind behind all of this. And so being able to have him on here to give us a talk today is a big deal. And I'm really excited about it. Doug really doesn't need an introduction. And he humbly, every time I ask him to send me an intro, he sends me about 6 words. So he really doesn't need an introduction, but just to give a couple points, he's currently out in Duluth, Minnesota at Essentia Health. He's the director of musculoskeletal ultrasound in the departments of ortho and radiology. Doug has done a substantial amount for sports ultrasound in general, for AMSSM throughout the past number of years. He's prior co-chair of the sports ultrasound committee with AMSSM, and really helped essentially create and develop most of what we have within our sports ultrasound community. So we're really lucky to have Doug give up some of his morning here to give a talk. And today he's going to be going over something that admittedly I don't do a ton of. I don't think a lot of us do a ton of this, so it'd be really helpful to learn some protocols and pearls from Doug on evaluation of groin hernias. So Doug, it's all yours, my friend.
All right, Ryan. Thank you for that kind introduction. So my topic is going to be the ultrasound of groin hernias and present a case per our protocol. And it's a little bit off topic, as Ryan mentioned, a little deviation from the classic orthopedic cases that we present. But my hope is at the end of this case that you'll see the value in learning how to perform the ultrasound value of groin hernias, as well as realize that it is very doable. So, there we go. All right, so I don't have any disclosures. So why discuss groin hernias in the setting of sports ultrasound? Well, we don't want to limit our anatomy and our understanding of groin and anterior hip pain just to the anterior hip joint and hip musculature. If we understand groin anatomy, then it broadens our differential diagnosis. And I've had a number of cases where if I did not know how to perform the groin hernia evaluation, I would have missed the diagnosis in athletes. And so again, I think it just broadens our differential and broadens our diagnostic capabilities. Last week in preparation for this talk, I keep careful records of all the diagnostic ultrasounds and procedures that I do. And I looked at the number of ultrasound exams I have done specifically that were referred for groin hernias. And it turns out about 10% of all the diagnostic ultrasounds that I perform are for rule out hernia. Oftentimes they come without any type of workup, and they want to know if their anterior hip or groin pain is related to a hernia. Interesting, the second most common diagnosis for referral is pain post-op herniorrhaphy. And the most common diagnosis the ultrasound reveals, as you would expect, is a hernia, just a little bit less than half. Now, interestingly, the most common other diagnosis that was unsuspected when I do the hernia exam is hip osteoarthrosis. So again, it kind of speaks to, if you're going to do a lot of work at the anterior hip, it's probably worth learning how to perform the evaluation for groin hernias. So our case today is pretty straightforward. So this is a 44-year-old college baseball assistant coach who developed left inguinal, or actually it was right inguinal and testicular pain after doing deadlifts. The examination by the team physician in the training room was suspicious for a hernia and was referred for a diagnostic ultrasound. So what is my protocol? So my protocol is divided into the anterior hip structures and the hernia evaluation. And we've talked a lot about the importance of looking at joints. And in this case, there's a fair amount of clinical overlap between pathology at the anterior hip region and that of the groin. And so I started out doing this, a number of years ago, and I have found this protocol to be invaluable when I include both the anterior hip and the hernia evaluation. Now, if clinically indicated, I'll go ahead and expand into medial hip structures, but it's not a part of our standard protocol. So let's just look at some of the images, jump right into the case of the anterior hip. And again, this is not really an anterior hip discussion, but we're just going to show the images in the protocol. And so to the left here, we see obviously the anterior femoral head. We see the anterior recess of the hip. And then we're going to translate our probe proximally in this long axis position and look at the anterior labrum. And for those of you just getting started, this hypoechoic area underneath the labrum is not a tear. This is a cleft. And for the anterior labrum, a cleft exists about 50% of the time. So again, don't misinterpret this as an anterior labral tear. Now, this companion case, just to illustrate the importance of looking at the anterior hip, this is a 31-year-old male who was just simply referred to rule out a hernia because of groin pain, no prior workup. Well, the ultrasound evaluation was negative for a hernia. And so here we see fairly unremarkable looking at the anterior recess. But when we slide our probe over the labrum, we see a complex anterior acetabular labral tear. And so in my report, obviously I report that there's no hernia, but suggestive of hip pathology, which referred to sports medicine, got worked up, radiographs, MRI, had fairly advanced hip impingement, was referred back for a diagnostic injection before arthroscopy. So again, the importance in the protocol of also looking at anterior hip structures. Now, after I look at the anterior recess in the labrum, then I turn the probe 90 degrees in the short axis or anatomic transverse plane. And I do what's called just a survey of anterior hip musculature. So I'll translate the probe laterally, I'll translate the probe medially, and just take a look around. And if I don't see anything, that might be the end of it. In our protocol, we do have the long axis of the iliopsoas, rectus femoris, and sartorius muscles as part of it. And then the last thing I want to mention, just in general, when assessing the iliopsoas muscle and tendon, or complex as we call it, it's important to translate the probe proximally beyond the acetabulum. And so here you see the bony acetabulum. And the reason why is sometimes the inferior or caudate border of an iliopsoas bursa is cephalad to the acetabulum, and you may miss it. And there's nothing more embarrassing than doing a hip injection or reporting a normal anterior hip, and then an MRI shows a big iliopsoas bursa that was missed. So for whatever reason, you're scanning the anterior hip, let's say pre-injection images before a hip injection, make sure you just scan proximally up the iliopsoas muscle and to be sure that you're not missing a bursa. All right, so the anterior hip images should just take 2 or 3 minutes. They go pretty quickly. And then we get to our hernia evaluation. And I divide the hernia evaluation into 3 sections. The first section is looking at the femoral area and assessing for a femoral hernia. The second is the inguinal area. And then the third is the Spigelian area. And this is included in our protocol, and I'll show you some cases and example of why. So it's important to take a systemic approach since each type of hernia has a specific anatomic defect. So let's jump into the anatomy. And when I discuss the anatomy of the hernia, I like to distinguish between book anatomy and what I call clinically relevant anatomy. So we'll start with the femoral area and the femoral triangle. And traditionally, the femoral triangle is going to be sartorius, adductor longus, and inguinal ligament. But the clinical relevant anatomy is right here at the superior pubic ramus. And at the superior pubic ramus, we look for several structures that are fairly easy to find and identify. So if we slide the probe over from our position, looking at the iliopsoas medially, we're going to look for the femoral artery. Medial to the femoral artery will be the femoral vein. Underneath will be the muscle fibers of the psoas major. Lateral to that will be the psoas major tendon. And then we look for the pectineus muscle kind of sitting in the saddle of the superior pubic ramus. Now, technically not part of the femoral triangle but directly superficial to the pubic tubercle will be the spermatic cord or the round ligament in females. So this is what I call the home base of the hernia exam. So let's just take a look at that. And so here we are at the iliopsoas. I'm going to just translate my probe medially, and right away and easily we see the femoral artery, femoral vein, muscle fibers of the pectineus, and we're going to continue our scan medially, and we see the pubic tubercle, the bony contour of the pubic tubercle. So this is the home base, and directly superficial to the pubic tubercle, we see the spermatic cord. So every time I start a hernia exam, I start with this image. And if somehow I get lost or need to start over, I often start in this position, and I'll show why, and that it's easy to find other structures starting from this position. All right, let's go to some inguinal or the relevant inguinal anatomy. And so this is an anterior aspect of the right groin and hip area. We'll just zoom in a little bit here. And we're going to look at the structures of Hasselbalch's triangle, which is fairly straightforward. So in Hasselbalch's triangle, superior laterally, we have the inferior epigastric artery. Inferiorly, we have the inguinal ligament. And then medially, we have the rectus abdominis, the lateral border of the muscle. And that forms Hasselbalch's triangle. But there's two structures that are key in this region. The first structure is the inferior epigastric artery, very important to identify when assessing for groin hernia, specifically the inguinal hernia. And then secondly is the spermatic cord or round ligament, which transverses through Hasselbalch's triangle. Now, the floor of Hasselbalch's triangle is the transversalis fascia. So let's look at the inferior epigastric artery. Very easy to find. And so if we go short axis or anatomic transverse on the rectus abdominis at the inferior border, we're going to see the inferior epigastric artery. So what we're going to do is just take our probe and translate it distally until we see the origin of the inferior epigastric artery and its takeoff from the iliac artery. So let's just take a look at that. Pretty straightforward. We see the artery flanked by two veins. We're scanning down, and then we're going to see it go right at its origin in the iliac artery. Again, pretty straightforward, very doable. And so that's the first structure you want to be familiar with. The second structure you want to be familiar with is the spermatic cord or round ligament. Again, this is very easy for the most part to find, more so in males and females. But again, if we go back to our home base and that femoral area, we look for the pubic tubercle, we're going to see the round ligament or the spermatic cord. If you have trouble, particularly in males, you can just scan slightly more distally into the scrotal area, and the spermatic cord will become more conspicuous. And then I'm going to just rotate the probe in an oblique position. So now I'm on the true short axis of the spermatic cord. Again, pretty straightforward. And I'm going to take and translate my probe distally to proximally. We're going to see the spermatic cord around ligament go over the iliac vessels, and then you're going to see some shadowing as it dives deep into the internal inguinal ring or the deep inguinal ring. So let's take a look at that. So here we see spermatic cord, a little bit of bony landmark. The pubic tubercle will be right here, but I just turned on it in oblique fashion. We'll see the cord go right over the iliac vessels, and then simply as it goes over the vessels, it's going to just take a dive and disappear, which is hard to see, but now we see this shadowing going down. So once we see shadowing, then we know we're at the deep ring. Let's just take a look at that one more time. So we see spermatic cord over the iliac vessels, and then take a dive deep right there. Now we see the shadowing going down, and that's going to be the deep or internal ring. When assessing for groin hernias in the inguinal hernia, it's important to have the spermatic cord or round ligament in the inferior epigastric artery in the same image before performing a Valsalva maneuver. And this is best achieved in the long axis view of the spermatic cord or round ligament. So from this position, again, fairly easy to find this position, we're simply going to translate the probe 90 degrees, and so we're parallel or long axis to the spermatic cord in this situation. So let's see how that looks. So here we are, short axis. And all I'm going to do is take and rotate on the spermatic cord. To the right is distal, to the left is proximal, and I'm going to look for the inferior epigastric artery. And so what we see here, spermatic cord going distally, wrapping around, shadowing going down to the deep ring, and I have the inferior epigastric artery in view. So this is a key image, and again, it's not that hard to get this location if you take a systematic approach. And if you're not sure about the inferior epigastric artery, you can certainly put the Doppler on and confirm what you're seeing is truly the inferior epigastric artery. So in this important probe position, if I slide and I can see the deep ring, typically I'm going to be slightly cephalad to the inguinal ligament, and this is considered what's called the indirect area. If I translate the probe slightly medially, still having the inferior epigastric artery in view, oftentimes we're just slightly caught at over the inguinal ligament. This is considered the direct area. But my experience is there's considerable overlap, and as long as you're on the cord, you have the inferior epigastric artery in view, then you're going to be pretty close to the right spot. All right, and then the last bit of anatomy is we go to the Spigelian area. And here we're going to translate the probe in the short axis or anatomic transverse up the rectus abdominis. And first, we're going to see that the aponeuroses of the external oblique, internal oblique, and transverse abdominis muscles are going to coalesce and then form a sheath or an aponeurosis above the rectus abdominis. But as we continue proximally, we're going to see that the internal oblique aponeurosis splits, forms with the transverse abdominis aponeurosis, and now splits the rectus abdominis. And so now part of the aponeurosis goes inferior to the rectus abdominis muscle. Now deep to that is the transversalis fascia. And so where this transition occurs is called the arcuate line. So to transition from, if we go proximal to distal, where the aponeurosis now goes above the rectus abdominis. And it's at the arcuate line or distal to the arcuate line that we see most commonly the Spigelian hernia, which we'll look at. All right, so that's our anatomy. And the last thing I want to just talk about is Valsalva maneuver, because it's very important. So if we have an insufficient Valsalva maneuver, then we may get a false negative result. Too robust of a Valsalva maneuver may make it very difficult to keep the probe in an optimal position. So I have a couple tricks. My most common trick is I have the patient take a deep breath and not push down, hold it for just a second or two, and then very gently start to push without letting air out. And that way there's not just a sudden jolt of the abdomen and you slide off. Sometimes I have them put their hands behind their neck and just do a modified crunch. I can put the hand on the abdomen and gently have them push against it, or we can have them cough. But performing and getting good at having the patient perform an adequate Valsalva maneuver is important. And then finally, we don't have a negative hernia exam until we have a negative standing hernia exam. I have dozens of cases where they were completely negative, even with great Valsalva maneuvers in the supine position, but we see it in the standing position. All right, so let's go back to our case now after that anatomy. So here we are in that short axis home base position, looking at, again, femoral artery, femoral vein. This would be femoral canal. And so we're going to focus our attention here as we have the patient Valsalva maneuver, and we just don't see any tissue coming up between this interval in the femoral canal. So let's just look at a couple quick cases of a femoral hernia. So this now is on the left side, and so to the left is medial, to the right is lateral. This is the iliac or femoral vein. This is the area of the femoral canal where we'll focus our attention. We'll have them Valsalva and we see tissue come up. Anytime I see an abnormality in this view, then I will always like to see hernias, including the inguinal hernia, in orthogonal views. So I'm simply going to take the probe, turn 90 degrees directly over the femoral vein, and then just translate the probe slightly medially. And so this is the image we get. To the right is distal. Here we see pectineus. So the femoral vein is going to be medial to my probe right now, and this would be the femoral canal. And so as we Valsalva maneuver, we just simply see fatty tissue going through the femoral canal. And then here's a second case, again, a left hip We're going to focus our attention again right here. This is a 62-year-old female who's 2 years out from an inguinal hernia repair, still having symptoms. And we see now that she has a femoral hernia come through the canal there. And again, we're going to always translate and look in orthogonal view. So here we see in long axis. All right, back to our case. And so this is the image that we just looked at, and we did not see a femoral hernia, but we're just going to show this again. And right away, we see that the inguinal canal and cord is large and expands with Valsalva maneuver. So what I do in this situation is, after I check for a femoral hernia, I'm short axis on the spermatic cord as we demonstrated in that illustration, and I'm just going to slide proximally and have them Valsalva maneuver slightly more proximal than the pubic tubercle. And so let's just take a look at that. And so here we are on the spermatic cord again. We're slightly more proximal, and bang, we see bowel coming right, come right at us. So clearly there's a hernia there. But in this view, we're not seeing the inferior epigastric artery. And so this could be a direct or indirect. And so again, now I'm going to translate my probe long axis as we demonstrated before. So to the right is distal, we see spermatic cord, we see it dive down, shadowing into the deep ring, and we have the inferior epigastric artery in view. And so I had him take a deep breath, not push, and then very slowly push. And before that, I'm just seeing normal breath here. So I'm making sure that what I'm seeing is the inferior epigastric artery. Now I have him take a breath and slowly push a little harder, nice and gentle. I'm still on my plane, and bang, we see a bowel-containing hernia come up and over or lateral to the inferior epigastric artery. So this would be an indirect hernia. And then finally, I'm just going to show this one more time, because it's important not only to assess where the hernias come in relation to the inferior epigastric artery, but is it completely reducing? And so when it goes back down, if it's not reducing, I apply probe pressure and see if I can fully reduce it. And so there's three things that we want to assess for when we see it in a hernia. The first is the contents of the hernia. Is it fat or is it bowel? Second is the location in respect to the inferior epigastric artery. And then third, is it reducible? So let's just take a look at a couple other cases here. And so now we're on the left hip, inferior epigastric artery is labeled. To the left is distal. Now this is the deep ring coming down spermatic cord. We're going to have them Valsalva, and now we see that the hernia contents are coming medial to the inferior epigastric artery. So this is a bowel-containing direct inguinal hernia. Let's take another look at a direct hernia. So inferior epigastric artery, I guess you'll have to trust me because the hernia is already coming through. This is lateral, so medial is to the right. And we can see a fairly large indirect, not indirect, but a direct inguinal hernia. This was surgically proven. So again, we're keying on the inferior epigastric artery and then have them perform a controlled Valsalva maneuver. And then finally, this is another companion case. So when we get right on the inguinal canal, we see right away looks like there's a hernia there. Inferior epigastric artery would be right here, deep ring would be right here. And so as we have them Valsalva, it does advance in the inguinal canal. But then when we have them relax, now I'm applying probe pressure, and the hernia does not reduce. So this is a non-reducible indirect inguinal hernia, often is called an incarcerated hernia. And I don't use that term because it's often mistaken for a strangulated hernia. So I use the verbiage non-reducible. If I see this, I'm also going to put the Doppler on it, particularly if it's a bowel containing, to make sure I see blood flow. All right, and then in our protocol, we have what's called a trans of the direct space. And I don't always do that, particularly if I see a hernia right away. But the direct space, again, is going to be medial to the inferior epigastric artery. And what I'm going to do is have the probe where I see one part of the image, the rectus abdominis, the other part of the image, the spermatic cord or round ligament, and in between is going to be the transversalis fascia. And so here we see a 45-year-old former college punter. He's had hip pain all through his career. It's gotten worse. over the last 6 months or so. The regular sort of images for the hernia exam were negative, but then I went to this image here. We see rectus abdominis, we see spermatic cord right here. And now when he Valsalva's maneuver, we see contents come up and through. And I suspect what this was insufficiency of the transversalis fascia, the so-called sports hernia, that now is advanced to a defect, which then converts it to a direct hernia. And so this companion case here, so we see rectus abdominis on the right, spermatic cord on the left. So this would be the transversalis fascia. And we can see already that it looks like there's insufficiency. And then when we have this patient Valsalva, we see that it bulges, but there's no true herniation. So this would be the transversalis insufficiency, or the so-called sports hernia. So I don't always do that in the protocol, but in cases where it's clinically relevant, then I check it. And then lastly, we go to the Spigelian area. And so in this particular case, if it's negative, sometimes we don't take a video. So rectus abdominis, this would be what's called the Spigelian fascia. And then to the left would be the abdominal musculature. And so in this case, it was negative, but let's just take a look. This is a companion case of mine where this patient had a non-reducible fat-containing indirect inguinal hernia, right side inferior epigastric artery would be here. So I cannot reduce this. Well, I can, but then it kind of came right back. So it's non-reducible. But then part of a protocol is we go to the Spigelian area. We see rectus abdominis on the right. This would be transversalis fascia. And when we had the patient Valsalva maneuver, sorry about the resolution of the video, we see fat-containing contents come through, not violating the aponeurosis of the external oblique. So that's a dual Spigelian and inguinal hernia. We would have missed this if it wasn't part of our protocol. So here's a very obvious Spigelian hernia, and someone referred for suspected of an inguinal hernia, did not have an inguinal hernia. So here we see rectus abdominis, and you can see clearly bowel contents going right through the aponeurosis, but not, again, violating the aponeurosis of the external oblique. All right, so we go to our report. So complete ultrasound of the anterior hip and inguinal region. This is actually the actual report on this patient. I just typed it out. So indications, right, groin pain, rule out hernia, technical, and then findings, there's no hip effusion. Basically, everything was normal of the hip. And then I go down to another paragraph and I state that there's no signs of a femoral or Spigelian hernia with Valsalva maneuvers. And then as a separate paragraph to emphasize, there's a bowel-containing inguinal hernia that arises lateral to the inferior epigastric artery with Valsalva maneuver. It completely reduces with abdominal wall relaxation. So the conclusion is an indirect inguinal hernia. If it was negative, so I did not see a hernia, I would have said there was no signs of a hernia with Valsalva maneuver, both in the supine and standing positions. All right, so in summary, the evaluation of groin hernias is doable. So everything I presented is not hard, just takes a little practice, but these structures, are not that hard to find working our way around the anterior hip. We need to focus on the relevant anatomy as presented. And again, adding the evaluation of groin hernias to your ultrasound armamentarium will improve your anatomy of the hip and groin region and expand your diagnostic capabilities. All right, questions or comments?
All right, thanks, Doug. As is almost always the case, you somehow take a fairly complicated region and fairly complicated scans and make them seem like potentially some of the easiest scans possible. So I really appreciate that. And, I think, at least for me, admittedly, like I mentioned earlier, I certainly don't do a ton of hernia scans. I think for me, and certainly something that I should be better at, I'll do a quick brief look for a transversalis insufficiency injury or sports hernia in our athletes. And then outside of that, I'm pretty quick to send this elsewhere for further evaluation for true groin hernias. And, I think that's, these have probably seen me certainly more than I have seen them. And, looking at your protocol, I think for me personally is, going to be clinically a game changer for me to add this into my protocol. I don't have a lot to add. I think, like you mentioned, and is on this slide right here, I think anatomy is critical here. And when we talk about sports hernias, I think a lot of time, or hernias in general, I think a lot of times we throw these words around, true hernia, sports hernia, athletic pubalgia, core muscle injury, and oftentimes I don't think that we really know what we're talking about. And I think it's helpful, identifying and discussing the relevant anatomy when you're doing these scans, and specifically in your report, to really describe what we're seeing. I think you could probably ask 10 people what a sports hernia is and probably get 4 to 5 different answers. And so I think knowing the anatomy here, specifically for these hernia scans, their relationship to the epigastric vessels and so on and so forth. One question that I have, Doug, and I think you'd be the best person to ask. Like I said, I scan these on athletes, which are typically very thin, no adipose, no nothing else getting in the way of these scans. I mean, do you find that these are doable, with a high degree of certainty in folks that, aren't lean, fit, very skinny athletes?
Yeah, good question. Interestingly enough, sometimes the anatomy is a little bit harder in our thin athletes because there's less adipose tissue, and sometimes the adipose tissue allows contrast, let's say with the spermatic cord. It's been really rare. I mean, I probably have only, of the, over 1,700 of these I've done, I've probably had 1 or 2 patients where I've even used a curved probe. And so I found that if you kind of stick to at least the way I systematically go from the femoral area to the inguinal area and how I look at these structures, I haven't found much of a problem. I'm actually doing a study right now where I'm retrospectively looking at all my hernias and comparing my read to the surgical results. And as it is, I mean, we're about halfway through, and some of the discrepancy comes if it's a direct versus indirect. Sometimes, the way the hernia comes out, it's hard to tell. And even some of them where I've gone back and checked my scans and say, clearly I'm seeing that coming up, medial to the inferior epigastric, but no, the op report said it was indirect. But if I look at whether there's a hernia there or not, whether I called it a direct or indirect, which really in a sense doesn't matter for the repair, I'm 99+% accurate taking all comers. And so most of these are not athletes. And so again, I think over time, I've just sort of morphed into this systematic approach. It's easy to teach the sonographers and partners to do it. And it at least has been pretty accurate so far.
And then when you have them stand, Doug, so obviously when they're supine, laying down, it's somewhat easy to drape them and whatnot. I guess I'm just trying to think ergonomically when you're scanning this somewhat intimate area while they're standing. I guess, how do you have them? How are they standing? How are they draped? How do you do that?
Yeah, so when they're standing, they're in a gown, and I have them next to me on the right side. The machine, is in front of me, and they're facing away the machine. So I'm looking at the machine, and I literally just kind of put my hand under the gown. And you're right that standing, it gets a little more challenging with the anatomy than when they're laying down. So I would say 100% of the time, I find that home base image that I talked about in the, in the femoral triangle, because I can find the hip joint standing, I slide the probe over, I find that short axis image of the femoral area, I find the cord or the round ligament, and then do exactly what I say. I scan up the cord, I'll have them Valsalva a couple times in that short axis, and then I'll turn on the cord there and get in long axis with the inferior epigastric in view. And so if I just simply try to find the cord or the round ligament standing, yeah, I'm gonna just flail for a period of time and have trouble with the anatomy. So again, it's kind of that systematic approach that, as you allude to, it gets a little more challenging standing, but we've been able to do it. And by just slipping kind of the hand under the gown and then finding that anatomy, the patients are usually, don't feel too uncomfortable.
Great. That's helpful. I think somebody may have unmuted themselves. Is there a question?
Yeah, hey, this is Matt Lunzer at University of Vermont. It's a quick one. I was just wondering about differentiating fat versus bowel.
Yep, good question. And it's easy to get in the rabbit hole because I didn't even mention the cord lipoma and how that can mimic fat-containing hernia. But fat is going to be a little more homogeneous, where bowel you're going to see more heterogeneity. So you're going to see air. You might see stool material. You might see shadowing, which what we saw in a couple of the examples I gave, where fat is going to be much more homogeneous as it goes up. And so that's probably the biggest distinguishing factor between the two. Did that answer your question?
Yeah, that makes sense. Kind of what I figured. Yeah.
Yeah. And I've made not again to get in this rabbit hole, but I've tried, spent a considerable amount of energy trying to determine whether something is a fat-containing hernia or cord lipoma, which is not truly a lipoma, but preperitoneal fat that's globular, that looks like a lipoma, and they can herniate through and mimic a hernia. And the bottom line is that you can never be 100% accurate, but surgeons will at least my surgeons will tell me, if it's painful and you see it, they can cause pain and they treat it just like a hernia. So.
Great. Anybody else have questions or comments for Doug? Gone. All right. Well, thanks again, Doug.
Yeah,
was
my pleasure.
Incredible as always, and certainly something that'll help me get better when I'm doing these scans. So really appreciate you taking the time to do this morning. All right, we are, as always, off next week. Then we are back the following week. So 10/28, Alfio Lafade down in Emory will be giving a talk on proximal biceps instability, plus or minus tendinosis. So everybody have a great weekend, happy fall, and we'll see you in a couple weeks.